cardiac point-of-care ultrasound, or the POCUS cardiac ultrasound assessment. This type of study is a type of cardiac ultrasound assessment that is limited in scope, technology, and is target-oriented. It is not a transthoracic echocardiographic or critical care exam. The full or limited TTE exam evaluates the heart comprehensively. It requires an extensive training and certification process that is out of the scope of the practice of the anesthesiologist. The POCUS exam was born out of the need to have access to this powerful technology while not overburdening the provider with a detailed understanding of all the capabilities of a comprehensive study. In this lecture, we'll be exploring the basic building blocks of the POCUS exam so you can have a better understanding of the principles, targets, and limitations, as well as the technology requirements, including the probe selection and manipulation. We'll be discussing the IM framework. The main objective here is to use the information provided to get the best image possible and to know the limitations of the study. We will be using the illustrations and animations from the 3D model of the heart and corresponding ultrasound clips available at showmethepocus.com reference. We'll be toggling back and forth between the first and second pages of the heart assessment of the website. Let's go. Indications. The POCUS exam is primarily indicated for patients who are in shock. This includes a wide variety of patients who are hemodynamically unstable, including those who are in cardiac arrest. It also includes those patients who are in respiratory failure when you're concerned that the heart may play a role in the disease process. However, the exam can also be performed as a screening tool and can be used serially depending on the clinical condition. Others consider this as part of the physical examination and as an ultrasound stethoscope. Targets and curriculum. As stated by the first international recommendations on POCUS, POCUS aims to gather sufficient information to assess the physiologic status and essential differential diagnosis. This statement defines the overall scope of the POCUS exam and highlights the principles of POCUS in practice. The idea here is to reduce diagnostic uncertainty by narrowing the range of available diagnoses. The framework of POCUS is one that is simplified for the search for gross pathologic cardiovascular findings consistent with the clinical picture to enhance the diagnostic process. We are looking for specific targets. This exam is not meant to be exhaustive, as is the case of the TTE exam, where we are looking at conclusive diagnosis and monitoring of cardiac disease. When the findings of the POCUS exam are not conclusive, then referral to the comprehensive exam will be necessary. The targets of the POCUS exam are as follows: left ventricular dimension and function. This includes a normal or grossly dilated left ventricle. The function of the LV could be hyperdynamic, normal, hypokinetic, or severely hypokinetic. Right ventricular size and function. Elements here include a size that is grossly dilated or normal. The function can be grossly normal or abnormal. Next is determination of volume status, followed by pericardial effusion and tamponade physiology. Gross signs of chronic heart disease. This will include the dilated left atrium, left ventricle, right atrium, right ventricle. This also includes a grossly thickened myocardium, which can involve any of the ventricular chambers. Gross valvular abnormalities. This entails leaflet or massive cusp disruption or marked thickening. The presence of flail or anatomic gaps. It also includes the presence of SAM, large intracardiac masses, which include valve vegetations or visible intracardiac or inferior vena cava thrombi. The POCUS exam is carried predominantly in a binary fashion, the presence or absence of a target. The exam is performed without having to carry out specific measurements. Qualitative and semi-quantitative assessments are the only objectives of the interpretation of the study. An example of a qualitative assessment includes gross left ventricle or right ventricular dysfunction. An example of a semi-quantification of ranges of function include a hypokinetic left ventricle versus a severely hypokinetic left ventricle. These targets will be the focus of our Heart Series lectures, and they constitute the curriculum of this program. The curriculum objectives of the POCUS study, as well as the other applications of the POCUS exam, can be found here at showmethepocus.com. IM framework. Regardless of your POCUS application, including that of the heart, the exam should follow a IM framework. These stand for indication, acquisition, interpretation, and medical decision making. We discussed indications. Acquisition is thus next in line. We need to get the best picture possible so that we can make an adequate assessment of the findings. This is the focus of this lecture. The interpretation of the images and clips will be dealt in the following sections of the series. It is important to note that competency in POCUS is through a practice experience pathway. Every patient encounter where POCUS is used needs to be supervised until competency is achieved. More information on the different pathways and methods of assessment can be found here on this link. Technology. The POCUS exam uses 2D or M mode primarily. Color flow Doppler will be referenced here as it's part of the OSCE's requirements. However, guidelines do not recommend its use for the POCUS exam. We'll be using a phased array probe almost exclusively. Alternatively, we could use the curved linear probe, but its use is limited because of its large footprint. Regardless of the probe used, note the position of its indicator since it will be important to orient the probe in the patient's chest. Machine presets. Cardiac versus abdominal. Ultrasound manufacturers have created their own program settings that are aimed at optimizing image quality. The most common presets include that of the heart or the abdomen. We can tell them apart by looking at the image display and specifically the location of its indicator. In the cardiac preset, we see the indicator on the right, but on the abdominal preset, we see the indicator on the left side of the screen as displayed here. Both these clips are the same view and structures being interrogated. Apart from the difference on how these images are optimized, they're also mirror images of each other. The preset will be relevant since it will determine how we orient the probe in the patient's chest. This determines how we orient the indicator or notch of our probe. For now, we focus on the abdominal preset since it's the one that most ultrasound machines have by default when performing a POCUS exam. Just bear in mind that if you are not seeing the structures in the correct configuration, you may have selected a cardiac preset and will have to adjust the orientation of the probe indicator by 180 degrees. I must also warn you that some ultrasound machines may default to the cardiac preset when selecting or plugging in a phased array probe and automatically have the image mirrored. In these, the orientation of the probe's notch with regards to the patient's chest should be that described for the abdominal preset. I know this sounds confusing, so it is important to recognize the orientation of the cardiac structures in relation to the location of the probe's indicator. If you notice the structures on the other side of the ultrasound display, you need to rotate your indicator by 180 degrees. Patient positioning. Ideally, patients should lie on the left lateral with the left arm extended. It is likely, however, that you may not be able to change the position of a patient due to the hemodynamic instability. This will limit one or more of the following views. Ideally, you should be standing on the patient's right side if you are right side dominant. Windows and views. Sound waves need to penetrate the skin all the way to the heart in order to get echoes back into the probe. This means our main focus when examining the heart is to go in the soft tissue between the ribs. The cardiac windows are the spaces between the ribs where the probe is placed, and the cardiac views are the images obtained from these positions. The main cardiac windows include the left parasternal, apical, and subcostal, as shown on this model. The ideal standard set of views for the POCUS exam includes the parasternal long axis, the parasternal short axis, the apical fourth chamber, subcostal, and inferior vena cava view. To help you understand the locations of the cardiac windows, we'll be using a 3D model to help us with the orientation of the placement of the cardiac probe. The stickers that appear in the following model represent the footprint of the cardiac probe. You can also appreciate the orientation of the probe notch. This represents the orientation of the ultrasound marker or indicator. Again, this is for the abdominal preset and not for a cardiac preset. If you're using a cardiac preset, then the indicator on the probe should be at 180 degrees from these stickers. We'll be using the illustrations and animations for the 3D model of the heart and corresponding ultrasound clips available at showmethepocus.com for reference. To flip back and forth between the location of the probe on the skin and the corresponding plane, we can click here and then go back by clicking again in this button. Remember to visualize only as far as the structures of interest and not more, otherwise your resolution may worsen. Parasternal short axis view. The indicator of your cardiac probe should be towards the left shoulder. The probe is positioned between the third and fourth intercostal space. However, the area of interest may be along the left sternum, which is why it's called a parasternal view. So you may need to go up or down an intercostal space. This is the mid-papillary view. We're cutting through the anterolateral and posteromedial papillary muscle. The walls of the ventricle include that of the anterior wall, lateral wall, inferior wall, and the interventricular septum. Notice the distance that has been selected for this view, since it allows the sonographer to visualize these chamber walls clearly. Parasternal long axis view. After identifying the parasternal short axis view, we now rotate the probe indicator towards the right shoulder. We continue to observe the RV on the near field and the LV on the far field. We notice the left atrium, mitral valve, LVOT, aortic valve, ascending aorta, and right ventricular outflow tract. In this view, we visualize the anteroseptal and inferolateral walls of the left ventricle. We can also appreciate the descending thoracic aorta on this view. Notice that this sector is cutting through the anterior and posterior mitral valve leaflets. It also cuts through the right coronary cusp and either the left or the non-coronary cusp of the aortic valve. Notice that the distance cast by the ultrasound beam is much longer since we need to be able to visualize the thoracic aorta on the far field. This occurs at a distance of approximately 16 to 20 centimeters. Apical four-chamber view. The probe is placed in the fourth or fifth intercostal space. The orientation of the indicator is towards the right between the 3 to 5 o'clock position. We identify the much thicker and bigger left ventricle, then we have the right ventricle and the interventricular septum. The RV is not more than 2/3 the size of the LV and does not contribute to the apex of the ventricle. We also notice the mitral valve and the tricuspid valve as well as the atria. The walls of the left ventricle that we see correspond to the inferoseptal and the anterolateral wall. The interatrial septum can also be seen here. This view is a very challenging view to obtain in patients who are in the supine position and can be greatly improved if they lie right side up. Subcostal view. The probe is now placed 2 to 3 centimeters below the xiphoid process. Notice the orientation of the probe marker is towards the right at the 3 o'clock position. In the near field, we see the liver, RV, tricuspid valve, and the right atrium. In the far field, we see the left ventricle and atrium. This view may be uncomfortable for the patient since there is a degree of pressure applied to the probe. Notice that we can also visualize the intraatrial septum on this view. Inferior vena cava view. To get this view, the probe is placed 2 to 3 centimeters below the xiphoid process. The marker should be directed towards the sternal notch. Here we see a non-pulsatile inferior vena cava within the liver. We see the vessel entering the right atrium, then the tricuspid valve, and the RV. We may also appreciate hepatic veins draining on the inferior vena cava. We should be able to appreciate the echogenicity of the liver above and below this major vessel. Be careful not to confuse the IVC with the aorta. By sliding the probe towards the left, we will be visualizing the abdominal aorta. Notice that this structure is pulsatile and there's no liver tissue dipped to it. In fact, in some cases, we can see the lumbar spine. And of course, this vessel does not drain into the heart. Probe movements. Once you have selected and turn on the ultrasound machine with a cardiac probe, select a depth between 16 to 20 centimeters. The distance between any of these two dots represents 1 centimeter. However, this distance may be different depending on the machine you're using. The distance will be displayed on your monitor as is this case. What you observe on the ultrasound display is a sector of the ultrasound beam that the probe has cast. This sector can be adjusted for a wider or narrower width. This sector is less than 3 millimeters of depth, so it's very thin, which means very small movements will cause big changes on the structures you are interrogating on your display. We start evaluating an area of interest by getting close enough so we can make small probe movements in order to visualize target structures. Those movements include the following. Sliding. This is the probe sliding from one intercostal space to the next. The probe follows the contour of the chest on the patient's skin. The angle of the probe and the skin does not move. It causes the beam to move to a different plane. Tilting. This is the probe tilting on the same intercostal space. The probe is tilted in the direction perpendicular to the beam. The objective here is to be in the axis or plane that visualizes the target structures. Rocking. This is the probe rocking in the same intercostal space. The probe is rocked in the direction along the plane or axis of the beam. You'll be using this technique if you had, for example, a parasternal long axis view and did not get a good view of the aortic valve. You will rock the probe so you can visualize the valve better. Rotation. This is the probe rotation and occurs when you want to evaluate a structure at a different plane from the one you just did. An example will be going from the parasternal long axis to a short axis view, or the subcostal to an IVC view. Probe manipulation sequence. The sequence that I typically recommend is as follows. I start with the parasternal short axis view. I begin by sliding to get an overall idea of where the heart and view lie. Then I use tilting to go to the plane that has the cardiac view. Once obtained, I can then rock the probe to see structures that lie on the edges of the sector if they do not have good resolution. Finally, I rotate the probe to get to the parasternal long axis view. Imaging standards. The acquisition process begins by assessing a single view before assessing the next view. This creates a mental picture of the physiology and pathology that may have an impact on patient care. It is more like assembling a puzzle of the potential differential diagnosis. There are various ways of judging your image acquisition skills, and Show Me the POCUS has one of these. These have been modified from the POCUS certificate program offered by the ASA. In essence, what this means is that for every view you attempt at obtaining, 3 aspects can be used to judge your skills. 1. The correct axis or plane implies that all the structures of interest appear on the image or clip. Structures need to be differentiated from one another by optimizing contrast. 3. Finally, we have the depth so that you can see as far as the deeper structures you are attempting to evaluate. Other guidelines have different set of standards, including those of the 2022 CHEST guidelines on basic critical care echo, and can be seen here. Interpretation of the results. The following sections cover the I and M of the IM framework. These are the interpretation and medical management portions of the POCUS assessment. Let's go.